Let me just start by introducing the concept and welcoming our guest from around the world to the FIENS Virtual Visiting Professor. Just to explain, FIENS is an organization dedicated to international education in neurological surgery, primarily the founding and maintaining of residency programs in low and middle income countries throughout the world. It includes fellowships, it includes postgraduate education. Our virtual visiting professor program brings board members of FIENS, such as Dr. Hartl, to share their expertise with young neurosurgeons worldwide. And our concept is that we will have a young neurosurgeon act as moderator, introducing Dr. Hartl and also introducing the question and answer portion, because a big part of a visiting professor is speaking to them and interacting. So Dr. Hartl, after his introduction, will present a short talk on spinal surgery in low resource settings. And then we will open this up to questions, and we will encourage our young moderator to ask for questions or ask them themselves. Or of course, we will ask the students of questions. So it's important to start that interaction. So the first thing we'd like to do, Julie, if you could introduce who our guest moderator will be, they will be able to introduce themselves and Dr. Hartl, and you might help them with that as well. Thank you. Julie?
Can you hear us okay, Stu?
Now we can, yes.
Oh, perfect. Okay. So I'm delighted to be here in Dar es Salaam with Dr. Hartl and Dr. Zarina. So I have Dr. Zarina is one of the neurosurgeons in Tanzania here in Dar es Salaam. She has been very busy in theatre all day, so we're delighted that she has finished operating, and perhaps later she'll tell us what she's been doing. We've got Dr. Hartl visiting currently from New York. So he has a long-term collaboration with Muhimbili Orthopedic Institute, which is where we all are currently. So we've had a fantastic week this week with visitors from all over the world who come to join us for the week as part of the Global Neurosurgery course. And I'm sure they will both explain more about that. Would you like me to introduce Dr. Hartl and his talk, or should we hand over to Dr. Zarina?
If Dr. Zarina is not prepared to do that, she can moderate the discussion, but we'll just, could you just introduce her briefly and then you introduce Dr. Hartl?
So Dr. Zarina is here with me. She is a neurosurgeon working here in Muhimbili Orthopedic Institute, and I will let her say a few words about herself.
Thank you.
Hello.
Yes, hello. Oh my goodness, Dr. Zarina,
yeah.
Good to see you again. My goodness.
Good to see you too.
It's very good to see you. Please tell us about your experience.
Well, yeah, as introduced, I'm a neurosurgeon working at the Muhimbili Orthopedic Institute. I graduated in 2020, so I'm relatively young in the specialty. But I have grown up in neurosurgery and this collaboration for, I think since the first time that you were here. By then I hadn't even started residency. So yeah, this collaboration has been going on for quite a number of years. And there have been a lot of improvements in terms of knowledge, in terms of quality of service that is given to the patients right now. And we're very grateful that it's still going on, and hopefully we'll take over from our seniors and keep it going.
Well, thank you. Thank you, Zarina. We're very proud to see you. Please introduce our speaker.
Thank you. So this speaker that is going to speak is none other than Professor Roger Härtl from Weill Cornell, and he's going to speak minimally invasive spinal surgery. I don't think I'm qualified to introduce Professor Härtl, but please, welcome.
Very good. And Julie, we'll just make sure Zarina moderates the questions. And then Roger, would you like to take the floor, please?
So it's been, first of all, Zarina is more than qualified to introduce me, of course. That was very nice of you, Zarina. And Bob, I can tell you, you have a very soothing voice because it's been a little bit chaotic here. And people have been trying to get this to work. And to hear your, your voice in the background was very, very calming. So I want to compliment you on your, on your voice and your the impact that you had on us. So thanks for having me.
It's our pleasure.
I will talk about minimally invasive spinal surgery in low resource settings. And it seems to be maybe a little bit counterintuitive if you think about what minimally invasive spinal surgery typically entails, especially in North America and Europe, where we talk about all types of unusual and complex approaches to the spine to do instrumentation surgery. But I think that there are parts of MIS that are very, very suitable for low resource settings. And that's really what I would like to talk about. How do I forward? Can you see me or can you see us?
We can see you and we can see your slides. Maggie, do we know how to advance the slides or is that done there?
That's done there. They have the slides are on their computers, so they will just need to tab forward however they do on their deck. There you go.
Okay. All right, good. So my involvement in low resource and developing regions and countries goes back to when I was a medical student, and I came to Muhimbili the first time in 2008, and you can see on the picture here that was with Dr. Asha, who was running the program at the time, and he's still here. He was actually just in the operating room with us, and he's still the father figure and incredibly gifted and talented surgeon, of course. And that was in 2008, and this was just yesterday. So it's been, we've been working together for quite some time. It's been incredibly rewarding. There are challenges, there are ups and downs, but overall, I think the meeting this week really shows and demonstrates that the collaboration has been going incredibly well. This is a few years ago, that's Paul Young, who was here, and then over the years, some snapshots of some of the mission trips or the visits that we've been able to do here with a variety of surgeons. And Bob, obviously you've been here many times. This is Volker Sonntag, who came a number of years ago to teach cervical and lumbar anatomy. My chairman, Phil Steek, has been here many times. And so it's been an incredibly rewarding experience. And everybody has a little bit of a different take on working in these types of environments. And what has worked for us, for the Cornell team, after many trials and tribulations, so trying out various different ways of really making this collaboration work, what has worked for us is this concept of coming here once a year, sometimes twice a year. And we usually combine that with a course, just like the one that we're doing this week. So we have a few days of lectures, and then we spend time together in the operating room, operating the rest of the week. We're able to secure funding, and there's primarily donations from patients, but also from industries sometimes, to fund fellows from Tanzania to come to the US, to New York. But the thing that really has made a huge difference for our program is the possibility to fund trained neurosurgeons to come here for a whole year. And Julia, who you just met, is a great example. She's a neurosurgeon from the UK who's spending the whole year here. And then we have a research fellow, Anthony, as well. And that's obviously really a crucial part, because to have somebody here on the ground who works with the team in Tanzania and keeps up the communication is really crucial. And then what we've seen over the years is really that research is one of those things that we can work on together, because if you only have limited time available and don't spend a lot of time here physically, then obviously really teaching and training is a little bit of a challenge that happens over time slowly, but research is something you can really continuously do, collect data, and then analyze and write it up and hopefully publish interesting articles together with our colleagues here in Tanzania. And that's then again also a way to collaborate. So these are some of the fellows over the years. But the purpose of this presentation is obviously to talk also about minimally invasive spine surgery. Minimally invasive spine surgery has been defined by various groups, and I will refer a lot to the AO because I've done some work with the AO on minimally invasive spinal surgery, and this is one of the this is the definition that we came up with. This is really is really expert opinion, but essentially what it says is that you're trying to achieve the same goal as with open surgery, but you're trying to reduce the collateral damage to the spine by reducing injury to the muscle, to the tissues, to the tendons, and so forth. So that's the idea. And so you're avoiding essentially muscle injury by using the endoscope or tubular retractors or muscle splitting approaches rather than open approaches. And that's really the whole secret and mystery about MIS. You are with the pathology, what you do there is very similar to what you would do with open surgery as well. And if you look at the different types of procedures and regions that have been studied, you'll see that virtually now every region of the spine can be addressed for certain pathologies with less invasive or minimally invasive surgery. The idea is to have smaller incisions, less tissue damage, less blood loss, less postoperative pain, less complication rate, and those patients typically then hopefully home earlier and back to work or back to their normal lives earlier. So that's the rationale. And we just published this book last year with a host of authors with big names in MIS surgery, and that summarizes a lot of what I'm talking about. And then obviously we worked with the AO. There's an MIS curriculum that we've been working on with the AO, with AO Spine, that is available, unfortunately, only if you sign up for an AO course, but that's something that you may want to consider anyway. And we're actually having an online webinar over several weeks coming up that you can sign on. That is, I think, really nice if you want to learn more about what we've done with the AO on MIS. Now, MIS in resource limited settings, concerns, obviously, technology. Typically, we're familiar. It's typically a lot of expensive technology, and how does that work in so settings? What about switching microphones? What about training? Do you have access to training in these in this part of the world? That can be a challenge. What about instrumentation and fusion surgery? Costly, technically very involved. Is that really realistic? On the other hand, tubular or potentially endoscopic surgery. What about hemostasis? We've done tubular surgery. We just did a case here today. When you have epidural bleeding, for example, in an environment where you don't have all these hemostatic agents that we work with typically in North America and Europe, can be a little bit of a challenge. What about a drill? If you don't have a drill, how about the microscope? On the other hand, there are potential benefits, and I think the benefits are primarily for decompression procedures. So because we know that with tubular surgery, for example, there's a lower risk of infection. If you do it properly, you can actually avoid fusion surgery. So we talked about patients this week who had spondylolisthesis and lumbar spinal stenosis. With open surgery, frequently you would have to fuse those patients. But if you do minimally invasive approaches, in many of these patients, if they don't have mechanical instability, you can do decompression and you don't have to fuse. So potentially there's actually a huge advantage of MIS surgery for low resource settings. And then there's the whole idea of leapfrogging, and in these types of situations where, and then we saw that, for example, this week where we BrainLab donated a navigation system, and already we've used it now for the last 2 days, and the surgeons here immediately took on to that. And I think it's going to be something hopefully that they will continue to use successfully, and they make it better with navigation than many other surgeons around the world, because they're very enthusiastic and they really seem to see a value in this. And then endoscopy, spinal endoscopy is something that's not being done here currently, but I'm sure that would also be something that would be taken up very, very quickly and very successfully. We know an advantage of MIS surgery is the reduction in infection rates that has been published over and over again in Europe and in North America. And I'm sure that the same would hold true here, of course. Now, what is it that makes you a good MIS surgeon? And we came up with these points, or these kind of areas to focus on. And this is obviously true not only for MIS, for any type of surgery and spinal surgery. Target means patient selection. And especially with MIS, very, very important. You got to pick the right patient for the right operation. And I always say that the least invasive operation is the one that you don't do because the patient just doesn't need it. And so many times in spine surgery, especially in degenerative spine, we see patients having surgery, either the wrong surgery or for the wrong reason. And obviously tools and technology, a challenge, especially in this part of the world because of limited access. So what is it that you can do in MIS with those limited resources? There are things, and we'll talk about that. Surgical techniques, obviously they're the same, doesn't matter where you practice. For MIS, it's especially the over-the-top decompression, the tubular surgery. You need magnification, you need some bayoneted, some special micro instruments, but actually not that many. And I think that it is feasible to do that type of surgery here. And then teaching and training, testing, research. So you got to keep track of your patients and your outcome data. And the talent is certainly here. The talent is huge, especially Bob, you know that in Tanzania, you've operated here, and many others who are listening probably know that the talent is here. Just really the challenge is how to teach and how to train and how to make certain operative techniques available. And that's really what this is about. Number one is targets. So patient selection requires an accurate diagnosis. You have to understand the natural history of the disease, and then the likely impact of your surgery. And that's really the important part. We think and we know frequently that with MIS approaches, the impact of the surgery is much less disruptive than with open surgery. And that will then have an impact on your surgical decision-making. I have a whole talk about this. I find this really probably the most important part of MIS. But we're not going to focus on this too much. The technology, we're not going to talk about that so much. But this is really the key because we want to focus on decompression surgery today. So the principle of MIS surgery is really the idea that you can perform a bilateral decompression in the lumbar, thoracic, and the cervical spine with a unilateral approach. This is really not so revolutionary, but it is important to understand. And a lot of surgeons are not familiar with that. And when you do that, you minimize iatrogenic instability, which is the reason why then you can frequently decompress without having to do a fusion. And this is really the key for MIS in resource-limited settings. And it doesn't sound that dramatic or revolutionary, but it really makes, because of the great number of patients who have these types of pathologies, especially degenerative, it makes potentially a huge difference, and it really opens up then a number of patients for potential successful decompression surgery that could have a significant impact in these parts of the world. This is a great example, a very typical example, and we saw 3 or 4 cases like this just over the last 3 days here. Grade 1 spondylolisthesis with lumbar spinal stenosis. So these are patients who can be in a lot of pain. They can have neurological deficits. And I think if you can offer these patients an operation without fusion, you can really do good. And I think you can really build around this then a surgical service, a spine surgery or neurosurgical service or orthopedic surgical service that is very, very successful. Because once you become good in treating one pathology, typically that will then also leap over to other pathologies, and the system gets better, and therefore you will really build the whole spine service in this region. So traditionally, with open surgery, most surgeons would have to fuse this, but with minimally invasive surgery, you can frequently decompress this without having to fuse it. And this, again, is not a new idea. This was really published in the mid-90s. John McCullough and Paul Young. Paul Young was on the picture earlier. He still comes to Tanzania and Zanzibar. They published this is one of my favorite books in spine surgery. They published the idea of a unilateral open approach for bilateral decompression. And then it was really surgeons such as Kevin Foley, Rick Fessler, Larry Koo, and others who translated this open surgery into tubular surgery in the late 90s, early 2000s. And I think it was Sylvain Palmer who was the first one then to really publish tubular surgery for lumbar spinal stenosis. So the unilateral approach for bilateral decompression of lumbar spinal stenosis. And that's really the workhorse. It's probably the operation that I do most commonly these days. And the idea is, instead of making an open approach where you remove the ligaments, the spinous processes, the lamina, parts of the facet, you achieve the same goal with a much, much less disruptive tubular approach. And again, this is then an example. And instead of doing a fusion, you actually do a minimally invasive decompression. And in selected patients who don't have instability and patients who don't have mechanical back pain, which is really sometimes the majority of patients, you can do this very safely and very successfully, and that has been published. And these are the instruments that you use bayoneted instruments, and we have them all here. Over the years, we've been able to bring those over, and they're still here, and they're being maintained, and people take really good care of those instruments. And and they're not that many. So again, this goes along with the low resource settings. And what could be simpler than a tube, right? It's not fancy. It's just a tube. And if you go to other parts of the world, surgeons use syringes. They cut the syringes off and just use the syringes for retraction. So on the left side, you see an expandable tubular retractor. That's very expensive. That's very complicated. But really what you need is just a simple tubular retractor, different sizes, different diameters. And once you have them, you really don't have to replace them because they don't break. They last forever. This is, I think I took this in Mexico or somewhere where they use syringes. They just cut the 10 cc or 50 or 20 cc syringe. They cut the ends off and use those as a tubular retractor. So you can do that as well. It is nice, though, to have a drill and a curved drill in this case, a bovie with a long tip, and we bend the tip so we can look around it when we remove the muscle. And we put this together a number of years ago, these drawings, just to kind of walk surgeons through the step-by-step approach of doing a tubular over-the-top decompression. And it's always exactly the same. This shows you on the right side at L4-5. Placement of the tubular retractor over, it looks like it's on the facet joint, but it's actually a little bit medial. It's angled about 10 degrees medially, the tube. And then you bring in the microscope, or you can use the loops, or what we did today, you can use an exoscope. We had the Vision camera here that we've been using. And then you remove the bone, the ligament, and flavum. The tricky part is the over-the-top decompression. So we get to the other side. Dr. Shabani today did a marvelous job just watching him. And he did a really nice job getting to the other side and get a wonderful over-the-top decompression. Over the top, there's a movie about this. I watched that during COVID. It's actually not that bad. So it's a famous surgery. And this is a video. This is now looking over the top from the right side, over the top towards the left side. And some, this is really the tricky part of the surgery, and a lot of surgeons are not that comfortable with it, but it's worthwhile trying this out in the lab or with surgical simulation, or visit surgeons who do this routinely to become more familiar. We published this paper. Now this was really developed by Kevin Foley probably over the years, and Rick Fessler and others, but they never, as to my knowledge, they never really published it. So we put this together in a paper where we try to write up and sum up all the little tips and tricks that come along with tubular surgery. You know, what size of tube you use, what size, what approach, right side, left side. What do you do if you get a CSF leak? It can be very tricky to fix that. And we try to summarize that in this paper. And again, the key is when you go over the top that you tilt the tube and you rotate the table away from you, and then you get this vision under the spinous process. And over the years, I've been doing this really now ever since I started practicing at Cornell. So it's almost 18 years or so now. And I find myself doing less and less fusion surgery because you can eliminate fusion for a lot of the spondylolisthesis patients. For patients with synovial cysts, I typically decompress them. I don't fuse them unless there's a recurrent cyst or there's clear mechanical instability. Or when I do a two-level surgery where one level is clearly abnormal, L4-5 spondy, I fuse that maybe, but then the L3-4 level where a lot of patients have lumbar stenosis, I just decompress that. I call that a 1.5 procedure very commonly now. So you can avoid fusion surgery, which is nice. And now we also do this in the cervical spine. We published that. This was an elderly patient where we didn't want to do a multi-level open fusion. This patient had a myelopathy. So we just, with a tubular approach, we decompressed this one level from the back, and this patient did very well. And I again, in selected patients, I do this now all the time. Multi-level, Michael Meyer from Munich, he published this a number of years ago. You gotta make a different dilation for each level. And then we go slalom, right, left. So you you don't want to come only from one side because potentially you could destabilize one side more than the other. So you're trying to go slalom, right, left. And we can do 3, 4, even 5 levels. Every level takes about half an hour, 45 minutes. I explain that to patients, and it typically works out very well. For congenital lumbar stenosis, it's not great, but for patients who have degenerative stenosis over the years where they have ligamentous hypertrophy, it's a great approach. And then there are a number of tips and tricks and pearls. Foraminal stenosis you can treat, so you come from a contralateral approach. Central stenosis with neurogenic claudication. For a right-handed surgeon, typically it's safer to come in from the right side because you do most of your work with your right hand. Lateral recess stenosis, unilateral disc herniation, synovial cysts. So, we wrote this up, and sometimes these things change over the years. You change your approach slightly. Like in the beginning, like on the slide, I used to come from a contralateral approach for synovial cysts, and then I stopped doing that maybe 3 or 4 years ago because if you have a leak on the contralateral side, it's very difficult. So now I come from the ipsilateral side. So these things may change. This is a picture from Moy a year ago when we brought in 2 Medtronic drills. And I've been very, very hesitant to bring any type of equipment. We got burned initially because if you bring equipment and there's no maintenance contract in place, anything breaks down. I've never had a problem with things getting lost, or people always talk about, they're being sold on the black market. I've never, in 20 years, I've never seen that. The problem is really if something breaks down, that there's just no replacement available. But these Medtronic drills, they're still here. We used one today, and they did an excellent job really maintaining it. And I really want to thank the Moy team here for taking such good care of the equipment. Again, those of you who have an interest in MIS surgery, I encourage you sign up for this webinar. You can Google this. It's in April, I think April 12th is the first webinar. It's only an hour or so, and we have 4 or 5 sessions with MIS spine surgeons from around the world. I think Avelino Parajon is the course director with Richard Asseker. And the MIS curriculum is really about basic skills: how to use the microscope, how to use x-rays, how to use navigation, how to fix the CSF leak, how to use a drill, and then you put it all together when you use it in a particular surgery. Like we have a whole lecture about the microscope. Little tips and tricks. For example, here when you operate through a tubular retractor, always every tool you're always stabilizing the tool on the rim of the tube, and that allows you then to become more comfortable and use both hands. You use a drill in your right hand, for example, and the suction in the left side. So that makes you more efficient. And then we have all these other little tips and tricks that are listed in the curriculum. This is a case that we did a year ago at Moy. We brought the Vision system with the tubular camera attached to a camera that allows 2D visualization of your operative field on a screen. This is a patient that we did with severe lumbar spinal stenosis at L4-5. So this was done exactly a year ago. This patient was done here at Moy, and this is the camera which surgeons in North America use frequently for lateral surgery, because it's very difficult for lateral surgery to visualize. But more and more, I think it's also being used for regular tubular posterior lumbar surgery, and that's what we're using it here for. It's a very intuitive, very easy to use system, but you have to be comfortable with 2D. With a screen. So with a microscope, you have 3D. With the Vision, you have 2D. And it's a little bit of a challenge, and it's maybe not as good as the microscope. But it seems to work very well. And this was the case that was done last year, for example. I'm not going to go through the whole video, of course, but this worked out very nicely. And that's the decompression at the end, where you see the over-the-top decompression, and the dura is nicely decompressed. And then the closure. And this was the patient the next day. So patient did very, very well. And then the surgeons here got a CT scan to look post-operatively. And they've done about 4 or 5 cases, 4 cases now, and then another case today. So 5 cases. And this was submitted as an abstract to a number of different meetings. Now, about 7 or 8 years ago, a brain lab gave us a 2D navigation system, and we brought that over on 2 occasions, only for a week each. And we published the initial experience with the KIC 2D system back then, 7 or 8 years ago, for a trauma case where you navigate off fluoroscopy images. And this was, very successful, but the machine was only here for a week and went back to Munich. And now Brain Lab committed a 3D system that just came back last week again, and that's going to stay here for good. And this is very, very exciting. And we did cases yesterday and today with 3D navigation, and it went really, really well. And I think the surgeons here really like that. As we mentioned, we're currently here for our 2023 course, of course, and we're focusing on MIS. We had a virtual reality session. 3D navigation, intraoperative monitoring is here now. DePuy Synthes donated spinal implants for a neurotrauma study that we're launching, and then we also had Upsurgeon here who did a really nice demonstration for brain surgery approaches that was quite fascinating. And this is a navigation case that we did yesterday. Here we actually did a 1-level decompression and fusion. That was the first 3D navigated case that was done here. So the screws were planned pre-op by the surgeons. And then we did this case with navigated pedicle screws, and that went very well. So at the end, I want to again summarize. I think the benefits here are really for decompression surgery. And I think they are inherent benefits of minimally invasive spine surgery when it comes to decompression. Infection rate is lower, the bleeding risk is lower. You can avoid fusion surgery, which potentially has a huge impact here. And hopefully this will work out, and this will be confirmed over the next years. And that was really it. I think I'll leave it with that. And I want to thank you all for your attention, and I'm happy to answer any questions or comments if there are any.
Thank you.
I'll hand it over to Serena.
Yes, thank you very much, Roger. I'm so impressed at the similarities here to the advances in pituitary surgery and the techniques and the approaches. And like every American, we can make this very complicated, but you've made the point that we can also make it very straightforward and simple. And with very simple equipment, one tube can do wonders for an entire OR. So will our moderator be good enough to start drawing questions from the audience, please? Zarina, would you go ahead, please? Thank you. It's always good for a moderator to ask the first question if they're slow.
Thank you very much, Roger. That was an outstanding overview of MIS, not only in the industrialized part of the world, but also in the, we've been asked a million times, how do you feel this fits into training surgeons? Is it done right from the very beginning in parallel with so-called open surgery, or is it something that you must be a master of open surgery before you can even think about doing that? I ask you this because when I started my surgical training, this laparoscopic surgery was in the same place or a similar place, and we've seen where that's gone. So I'd be really interested to know what your philosophy and your thoughts are on that.
Sure. And for the audience is John Duff from Switzerland, who's a MIS surgeon himself. So, you know, what's really happening, I think in reality, what's going to happen is that surgeons are going to focus on one thing, and there's going to be a situation where there's going to be surgeons who do endoscopic surgery only, and they're going to not be very good with open surgery. That's the reality. But doesn't mean that it should be that way. I think especially in a place like here, by definition, you have to be an open surgeon. And it's probably at the level of Dr. Shabani and some of the more senior surgeons then who have a special interest that they will then adapt to tubular surgery right now. But I think in 10, 15 years, it's going to be like everywhere else, where it depends on who you train with, and there are going to be a lot of surgeons who don't know much about open surgery. And I'm not saying that that's right, but I think that's the reality, because this is how the human mind works, and that's how the reality is. But I think with surgical simulation, and we saw it today, for example, with virtual reality, you can also, I think, increase your ability to understand anatomy. I think not everybody has to spend, hours in the cadaver lab, or days or weeks in the cadaver lab, I think a lot of it is going to be really facilitated and maybe jump-started with technology. So people are going to understand the anatomy maybe better without going through the rigorous process of learning open surgery. And then the other thing is subspecialization. Not everybody is going to be doing everything within spine, even here. I'm sure in 10, 15, 20 years, there's going to be, some of you are going to be spine surgeons here, and some of you may only do, cervical spine, like, my partner Dan Rue in New York, or tumor spine surgery. I think that's, and then obviously that limits your window in a way, that you don't have to, you have more time to spend on a certain subspecialty, and they become really, really good at that.
Thank you.
We have a question from Dr. Ali.
Tell us your name again and where you're from.
My name is Simon Balogun. I'm from Nigeria, a neurosurgery resident. Currently attending the course. It's very interesting. Thank you very much, Professor, for this highly educating presentation. I was really interested in the improvisations which you showed during your presentation, especially the tubular, the use of syringes as a form of improvisation. I know it's not the best, but in settings like that of mine, where it can really help where the facilities are not available. Do you think the drill can also be improvised? Can this MIS spine surgery be done using rongeurs? I don't know. I just want your perspective on that.
Yeah, Simon, I want to say Simon is one of the most dedicated and involved course participants for sure, but he's been here last year and he's been coming here many years. So thanks for being so dedicated, and thanks for your question. You know, the syringe that I showed, I think Dr. Joe actually in Pittsburgh, he's still using that. You know, he prefers cutting those syringes. And so it's not necessarily that it's like a, you know, the lower level type of, you know, procedure. It's actually very, very efficient to do it that way. It's also cost efficient. It's probably much cheaper than using tubes, you know, that are expensive. But it's a one-time purchase, of course. The drill, that's a tough question. I mean, we had that discussion in the operating room. Dr. Shabani wanted to use the Karsten, and I talked him into using the drill. So I don't know, maybe he should answer that question.
Yeah, thank you, Professor Härtl, for relaying the baton to me. With the tubes, especially when the 7 millimeter tube, and if the procedure is only laminectomy and not discectomy, I've tried using the Kerston rongers, and it works well as doing the drill.
Yeah, so and we did a combination today, but I could see Dr. Shabani got a beautiful over-the-top decompression, and I'd be curious to see with the Karsten. I'm sure you probably would get the same result. So I think he's really good with the Karsten. So that's probably a viable option.
Yeah, and that's what I really want to follow with. How do you do the over-the-top decompression, the contralateral decompression with the Karsten?
Yeah, with the drill, I found you can even do without taking off the yellow ligament. But when you're using a Kerston punch, actually, you cannot pass above the yellow ligament. It means the yellow ligament with everything goes in a Kerston punch. Yeah.
Okay, we have one more question. Dr. Zileli from Izmir. He's a visiting surgeon from Turkey.
Hi. Yeah, very nice lecture, actually. It is very clear that our techniques are evolving, and then we are having new in our practice. What is your preference for tube? Do you use microscope or endoscope from the tube?
I use a microscope usually.
Okay. I also started with endoscope, then switched to microscope later. It is more comfortable. This is so obvious. But then I raised the question, I see nowadays there are surgeons who try to make a full endoscopic fusion surgeries. I mean, working from a 7.5 millimeter diameter tube with water irrigation system. So is it probably beyond our abilities to do something like this? What do you think? We will come to a point that human being has not that much of abilities, or gaining them will take too much time. Now we say actually there is a steep learning curve or something like that. And what do you think about this?
Yeah, so there are techniques, technologies that are being developed, and there's just a, I think one of the companies in North America came up with a comprehensive system to do a interbody fusion through a small tube like the one that you mentioned, and they have the visualization, they have the tube, they have everything that's really important for that procedure. And I think it's a very viable way of doing it. My concern with technology is that if the threshold to do a fusion is going lower and lower because now it's so relatively easy to do it, my concern is just patient care, that patients are going to end up getting a fusion with pathology that really otherwise we wouldn't treat necessarily, or we would just do a decompression on. And now because the technology is so advanced and it's such a low-hanging fruit to do a fusion, that patients end up getting fusion surgery for the wrong reason. That's my concern. But I think that the technology, I'm not worried about that it's becoming too complicated. I think the contrary is true. I think it's actually going to become more streamlined. It's just that my worry is the indications are going to change.
Roger, I think that's a wonderful point you just made, that this technology becomes simplified down to, like, you need magnification and you need exposure, and then you repeat it, and then it's available in the low and middle income countries. And the big point you made today was you often, with this technology, can avoid a fusion, which is vastly better for that health system if the person can be restored. We have a question from the chat from one of our younger people asking you to comment on the role of physiotherapy and the timing of that. Again, let's put it in the low resource setting after spine surgery. Timing and extent of physiotherapy with these technologies.
Yeah, what we see, and I can't comment on the setting here, obviously, because I don't know exactly what the access is to physiotherapy or physical therapy intervention. Certainly what we see where I practice is that these patients are being mobilized very, very quickly. You saw the picture, the patient that we did last year. She was in normal clothes essentially the next day and was released, which in North America would be pretty common, but here I think is probably very unusual. So the summary is really, yeah, these patients are being mobilized much earlier and therefore also have the possibility to undergo physical therapy much earlier than patients who have open surgery, and that's something that you should discuss with patients and with the families, and also you should work with the physical therapist then if you have a lot of patients, because it will be important then to instruct the physical therapist what to do and what not to do. But I think in the bottom line is that you can mobilize these patients much earlier and they can undergo physical therapy much earlier. Yeah, we have a question in the back.
Yes, Dr. Consolata.
Thank you for the talk. Professor, I have a question. So I heard you talked about one of the complications one can get is CSF leak intraoperatively. So how do you deal with the CSF leak, or if you encounter excessive bleeding during the surgery?
Yeah, good point. Last year we did a few cases and there was a lot of epidural bleeding, and didn't have gel foam, we didn't have thrombin, and that made me really wonder, and I was really worried because I suddenly realized, because I used to think tubular surgery is so straightforward, and then I realized, well, it's straightforward if you know how to deal with the bleeding, and if you know how to deal with the CSF leak, and it's very straightforward. But in a setting like here, it can be a challenge. So I think you have to think about this beforehand. I think you have to have some kind of strategy in place. How to deal with these things. And I don't have the ultimate answer for you because you understand better what's available and whatnot. We brought some gel foam and some thrombin now from New York, but I think you really have to think about what you would use. I think last year we used hydrogen peroxide, and that seemed to work, but I'm not sure if that's really the best option. CSF leak, same thing. You have to think about this. My general approach is that if the hole is big enough that a nerve root can leak out or can herniate out, then you should really try to get a primary closure and put a stitch in. And that can be difficult through a tubular retractor. So you may have to be prepared to take the retractor out and open it up and then close it that way, the way that you would close a leak if you had open surgery. That may be the best strategy for you. CSF leaks happen not that frequently, obviously, maybe 5% of cases, and then most of them are very, very small. But if you have to get a primary closure, then it may be better for you to open up and close it that way. So, And then obviously bed rest. You don't have lumbar drains, so that's a little bit of a challenge as well. But those are things you have to think about beforehand.
Dr. Boretta, would you like to say something? As one of the young neurosurgeons who is spearheading minimally invasive spine surgery.
Thank you so much, Dr. Zarina. Thank you so much, Dr. Härtl, for the nice presentation. I really don't have much to say rather than thanking you for coming here and for teaching us and for all your support throughout the years, most especially last year for the donations that you made in this year for the Brain Lab and the vision cameras and the IOM. Thank you so much.
Thank you. But again, that's obviously not, I just facilitated. So it's really thanks to many other people and the companies that donated this very openly and very, I think they did it with really great support and they're very empathetic towards everything that you are doing here. So thank you.
Dr. Francois, would you like to say something as a neurosurgeon that's trained in a developed country and a former global neurosurgery fellow that's spent a year in Tanzania? What's your experience?
Yeah, so thank you for the question. So my experience while coming here was, yes, I realized, of course, that you don't have the same tools and instruments and facilities and consumable that we just have by asking in our settings. And my impression was that I was really impressed by what you guys can do with what they have. And you are very good at finding a solution for when you have a problem and that you don't have what you need to solve it. I was really impressed. So that's, I'm very, very impressed by your skill for that.
I want to say Francois Waterkane from Belgium. He's a fellow who came the year before Julie. He came from Belgium with his wife and his 2 children. And it was wonderful to watch how happy your children were here also. And your wife was working and, she was a teacher in a school. So that was a great example of how you can really use this time in an extremely productive and pleasant way for yourself, but also for your family. So thanks for joining us here.
Dr. Shabani, would you like to say something as one of the senior neurosurgeons who have seen spine surgery from open and now transitioning into minimally invasive spine surgery?
Yeah, just in brief, I really thank Professor Hartl and the collaborating team for actually improving on the skills of the spine surgeons at MOI. Really, I saw when we started with the Lucky procedure for spine fusion, and now we're using pedicle screws. We started with rigid, with the rigid ones, and then we have which are more versatile, and we're moving forward now to minimal invasive and even the cutting edge technology, to the extent where now we can even participate in research. This is a good stride for us.
I think we're slowly running out of questions.
Okay. It's
there's one more question, and there's one more question in the Q&A section.
Let me take that, Jeannie, and change it a little bit if I could. Roger, the question is about the tubular system, and my question to modify that a little bit is it time that we included a tube in our basic spinal set? Do you think when we begin to develop these programs and training programs in the low and middle income countries, should we be emphasizing this? That's really the question of the whole lecture.
Yeah, that's a good question. I'm not sure, to be honest, because it really requires because it's not only the tubes, then you need some, bayonet instruments. And then, like I said, you have to, I think it would be better to try it in certain environments where surgeons have a real dedicated interest, and then see how that works for the next few years, and then maybe revisit that. But I would not, because even where we practice, a lot of surgeons are not that familiar with that. So I'd rather have surgeons take that on who really have an interest, and then see how far they can get with that, and then make that decision.
Well, let me take the FIENS prerogative of thanking people. Did you have another question there, Roger? You were going to?
Yeah, Dr. Kinasha is actually.
That'd be great.
Thank you very much, Professor Härtl, for your talk. I attended the MISS procedure this afternoon, and I was impressed by the fact that the equipment, the light source and camera, cost about $2,000 US, I was told, and you cannot re-sterilize the camera and light source. Is it possible for us to ask to see? It might be possible, because this is intended for low-income setups, whether they could establish a system that could be re-sterilized maybe once or twice or 3 times, because most patients would certainly not afford this procedure.
Yeah, that you bring us back down to reality, Dr. Kinasha. Thank you. Because yeah, of course, we brought these systems over, and they're single use in the US. And I asked the question to the company yesterday, and they said you're not supposed to re-sterilize them. So I don't know if that means that you cannot, or if they just don't want surgeons to re-sterilize it. Very difficult. I don't know. I don't have the answer. It's still cheaper than a microscope, though.
Yeah, but I think if we really look at the equipment that's basic and begin to think that as a new center develops, they're going to need visualization, microscope, endoscope. They're going to need straightforward reusable tools. A tube can be reused, and they're not going to have a fancy light source. They're going to use their endoscope or their microscope. I think we can do this. I really do. I'd like to ask Roger one thing. If you could provide Jeannie with the reference from the 2017 Operative Neurosurgery article, which summed up this procedure so well, we'd make sure that anybody that wants to view this webinar in the future will be able to have that reference right in front of them. That'd be wonderful.
Of course, with pleasure. I'll send that tonight.
You bet. And I just want to thank everybody there in Dar. There are many, many friends, and it's so great to hear and see you again. And I'm so happy that Roger's been really reopening the in-person courses these last 2 years. It's a profoundly important step that we make. And remember, we learn so much by participating. This is a very cooperative and two-way learning adventure, and this is what keeps us young. So thanks so very much to everyone for participating today on behalf of FIENS and behalf of these wonderful people. Roger, can't thank you enough. And Dr. Zarina, thank you for filling in so beautifully. Wish everybody well.
And thank you to everybody at FIENS.
It is our pleasure. Do take care and enjoy your evening there, as our day is starting here in the other part of the world.